Chapter 31, Alterations in Male Reproduction. In this chapter, we'll discuss acquired disorders of male reproductive function, and specifically, we're going to focus on erectile dysfunction. So, disorders of the penis and the male urethra can occur many ways. So, we have some congenital anomalies where you are born with this condition. You can also have acquired disorders, or it can be due to an infection or neoplastic, so related to cancer. So in this section, we're going to focus on the acquired disorder, and specifically, we'll discuss erectile dysfunction. So ED is impotence, or an inability to achieve or to maintain an erection that's sufficient for satisfactory sexual performance. So just because you have erectile dysfunction doesn't mean you cannot attain an erection. You may be able to, but you can't. You may not be able to maintain it, or you may not be able to achieve it, period. There are two ways it can happen. We have primary and secondary impotence. So in primary impotence, it's an inability to attain an erection throughout your life. So it's often related to psychiatric problems or vascular trauma during adolescence. Because again, an erection is where the penis fills up with blood. Secondary impotence is where you are no longer able to achieve erections, although you used to be able to previously. So what could account for some reasons why someone might suffer from secondary impotence? So the first is peripheral vascular disease. Again, an erection is the penis filling up with blood. So if you have an issue with the vasculature, you're going to have an inability for the penis to fill up with blood, hence the difficulty achieving an erection. So arterial insufficiency could be caused by an obstruction. It could be due to atherosclerosis and that plaque buildup really interrupting blood flow. We can have stenosis of the arteries or vascular endothelial damage. So the endothelial layer of your blood vessels are damaged and really impacts blood flow. Other issues could be endocrine related, so hormone problems, so diabetes, pituitary dysfunction like low luteinizing hormone LH levels, low testosterone, or high prolactin levels. And then medications can also contribute. So antihypertensive drugs like diuretics can alter the amount of blood that's available to go to the penis. Antihistamines, and we know those can increase capillary permeability and really reduce blood volume. And then we have antipsychotic drugs, and also some antidepressants have been shown to cause ED. And then a physical trauma, so a fracture of the pelvis or injury to the penis. And then we have iatrogenic causes, so surgery. This one, remember, is physician caused, so complications related to surgery. And then there can also be psychological causes as well. So if you do have ED, how can we treat it? So first we have to determine what's causing it. Is it psychogenic or is it organic? Could a surgical intervention be helpful? For example, insertion of an inflatable or semi-rigid prosthesis. There's also intracavernous injections. So we can inject vasoactive medications that impact blood vessels, and these are really going to cause vasodilation so that blood can go to the area. And then we also have selective inhibitors of cyclic GMP, like Viagra, Levitra, Cialis, and these are also vasodilators to increase blood flow. And if you want something a little bit less invasive or without taking medication, there's also vacuum devices. So then we're going to move on to alterations in female reproduction, and that's going to be covered in chapter 33. And really in this section, we're going to discuss menstrual disorders. So the menstrual cycle is typically 28 days long, and about 5 days of those 28 days is when you're going to mense or shed blood. And there can be alterations in menstrual cycle. Either the length of the cycle can be altered, or the length of the mense period, or the amount of blood that is lost. So here are some examples. So the first is amenorrhea. So in amenorrhea, it's an absence or a suppression of menstruation. So you have no mens, for example. What can cause it? Well, hormonal disturbances can cause it, as well as stress and neoplasia. So tumors of the pituitary or the adrenals or the ovaries. How do we treat amenorrhea? So it's aimed at understanding what the underlying cause is and to treat that. So if it's a hormonal issue, then that's how you will go about administering treatment versus if it's cancer related. So hormonal supplementation may be required or surgery to remove the tumor. Then we have menorrhagia. So menorrhagia is where you bleed between your menstrual cycles. So you have, let's say, a normal 28-day cycle. Again, that 28-day number is just an average number. But in between, you also bleed a little bit. So what can cause it? So you can have slight bleeding from the endometrium during ovulation. Also, a uterine malignancy, erosion of the cervix, endometrial polyps, or estrogen therapy are all causes of bleeding between periods. Then we have hypomenorrhea. So hypo, we know, means low. So in this case, we have a deficient amount of menstrual flow. So the amount of blood that you shed during mens is a lot less than normal. So there's reduced flow. So causes include endocrine issues as well as systemic disorders that interferes with hormone delivery and action, as well as maybe a physical obstruction of menstrual flow. And as a result, you have less blood actually leaving the body. There's also oligomenorrhea. So in oligomenorrhea, you have infrequent menstruation. So a normal cycle, we said, is about 28 days. So in this case, your cycle is much longer, so more than 35 days long. So if you have a menstrual cycle, or if you mense every, let's say, 40 days, that is considered infrequent, so oligomenorrhea. Causes, it could be endocrine, as well as, again, systemic disorders causing failure to ovulate. Again, by systemic disorders, we're talking about delivery of the hormones as well and action of the hormone. And then we have polymenorrhea. So polymenorrhea would be the opposite of oligomenorrhea. So in oligo, we have infrequent menstruation. In poly, we have increased frequency of menstruation. So your menstrual cycle occurs less than 21 days. So normal cycle, again, is 28 days. So if you're having your period every 20 days, you would be considered as having polymenorrhea. So causes, it could be, again, endocrine origin, or, again, a systemic disorder that's causing increased ovulation to occur. And then we have menorrhagia. In menorrhagia, you have an increase in the amount or duration of bleeding. So your cycle time is the same. So let's say, again, every 28 days you have your mens, right? Your menstrual cycle is every 28 days, or it's 28 days long. But the period in which you are bleeding is going to increase. So you're going to have prolonged bleeding and heavy bleeding. So it's increase in amount or the duration. Causes could be lesions of the reproductive organs. And then the last one is dysfunctional uterine bleeding. So dysfunctional uterine bleeding is where you have an abnormal endometrial bleeding, but it's not associated with a tumor or inflammation or pregnancy or a trauma or hormones. And so it's most commonly associated with the time in which you first have your menstrual cycle, and also menopause, where you now start to stop having a menstrual cycle. So during the first menstrual cycle, it doesn't happen perfectly the first time. So there's going to be a lot of changes or abnormal bleeding when you're starting to have your menstrual cycle, since you have immature functioning of the pituitary and the ovaries. So it's kind of everything starting for the first time. So it takes a couple of cycles or a little bit of time for it to kind of work properly. And so that abnormal bleeding during that time, yes, hormones are involved, because now you have these reproductive hormones released and things like that, but it's really not a hormonal effect per se. It's not all of a sudden there's a hormonal issue. It's now that you're starting, you're kind of getting used to the process. And so there's a little bit of abnormal bleeding going on. And then same thing with menopause. So during menopause, as you decrease menstrual cycle and decrease the impact of estrogen, as well as the release, everything kind of doesn't shut off like all at once. So you're just going to have abnormal bleeding a little bit until everything kind of stops. So the dysfunctional uterine bleeding is specifically related to the first period, as well as when you start to go into menopause. And so we'll end with a quick question. Which term should the nurse use to describe infrequent menstruation? So infrequent would be where your cycles are very long. So let's say you have a menstrual cycle every 40 days, and that would be oligomenorrhea. And that's it. Thank you.